Hello and welcome to our new topic. Today's topic is another great one, which is the drugs used in bone mineralization disorders, focusing osteoporosis as an example. As we know, millions of people worldwide suffer from osteoporosis today, which increases the risk of fractures, morbidity and mortality. So, let's start. The learning objectives are shown. Please take a look. Osteoporosis is the major and the main bone mineralization disorder which is commonly seen and affects both females and males, but women have a higher incidence. Osteoporosis is marked by a more rarefied bone substance, making it more prone to succumb to tensile stress, resulting in fractures. Osteomalacia and rickets is a nutritional deficiency of vitamin D in adults and children respectively, in which the bone matrix is formed but mineralization is not adequate, leading to formation of softer bones which may bend over time. The rarer conditions include osteoporosis, osteitis fibrosis cystica and Paget's disease of bone. Let's compare them in terms of their biochemical parameters, which differ between these conditions based on their underlying pathologies. Take a moment to study and reflect on the biochemical changes seen in this. For this particular lecture, we would use osteoporosis as an example. We will try to understand the underlying principles of approach which are applicable in treating such disorders. Take a moment to ponder and review this diagram. Bone mineral homeostasis is a complex interplay of different factors that operate to maintain the plasma concentration of calcium and phosphate. The intestines, bones, and kidneys are shown as major players in maintaining bone mineral homeostasis. The dietary calcium and phosphate are absorbed from the gastrointestinal tract under the influence of vitamin D and contribute to serum levels. The liver produces 25-hydroxyvitamin D, which is further hydroxylated in kidneys to 1,25-dihydroxycholcalciferol, also called calcitriol. The body would tend to maintain a suitable concentration of calcium and phosphate because both are useful in different metabolic pathways. Once the body has a surplus amount, it will be deposited in the bones under the influence of calcitonin hormone produced from the thyroid gland. The calcium and phosphate in bones add to the mechanical resilience of the bone itself, and they are an essential part of the skeletal strength and support. But apart from that, it also serves as a reservoir for calcium and phosphate. If the body needs calcium and phosphate, they are mobilized from the bones under the influence of parathyroid hormone. The pyramidal approach to prevent fractures in high-risk patients of osteoporosis includes lifestyle changes, which include a change in the diet, advocacy for exercise, stopping smoking, and alcohol intake. It is important to rectify secondary causes, for example, chronic glucocorticoid therapy and immobility. And once you are confident that these factors which contribute to bone loss are adequately been dealt with, then consider drug treatment. The drugs which are used in diseases of bone mineral homeostasis include vitamin D and its analogues, bisphosphonates, hormones, selective estrogen receptor modulators, wrinkle inhibitors, calcium-sensitive sensing receptor agonists. So, like any disease, the treatment rests on favoring factors which are beneficial in ameliorating the problem, and reducing the factors which underlie or predispose to the disorder. In osteoporosis, there are certain factors which will favor bone deposit, for example, calcium and vitamin D, parathyroid hormone, and then calcitonin and exercise. Please note that parathyroid hormone can be used in both types of disorders, bone deposition as well as bone resorption disorders. There are certain factors which oppose bone loss, for example, bisphosphonates, SERM are selective estrogen receptor modulators, and HRT, which is hormone replacement therapy. Parathyroid hormone is a hormone produced by parathyroid glands, which are situated at the poles of thyroid gland in the anterior part of the neck. The parathyroid hormone receptors are G protein coupled and calcium sensitive. Parathyroid hormone is an important player in induction of bone remodeling units. Now, what is a bone remodeling unit? Let's discuss this concept in the next slide. Now, what is meant by inducing a bone remodeling unit? Well, it includes the processes like resorption of bone by the bone-eating cells called osteoclasts, and deposition of newly formed but mineral-deficient matrix or osteoid by osteoblasts. Later, this osteoid will be mineralized with the help of different factors, adding to the physical resilience and hardness of the bone. This process can be depicted as a composite diagram, as shown here as a set of steps comprising of resorption, reversal, formation, and mineralization in sequence. As you could see, the endosteal sinus within the bones brings in the stem cells, which then change into osteoclasts, which are monocyte macrophage lineage cells. And these osteoclasts, they eat up the bone and remove a certain part of the bone tissue, and also invite the bone-laying osteoblasts to the site of this bone remodeling. The osteoblasts, in turn, will recruit more osteoblasts. So, it's just like a pavement or road repair work, where the surface preparation includes scraping off the existing layers to a certain depth followed by replacing it with new deposits. This simplified diagram shows that the bone remodeling is an interplay between different factors, like parathyroid hormone and vitamin D. We know that parathyroid hormone induces the recruitment of osteoclasts, but it also induces the recruitment of osteoblasts. Thus, it actually controls both events. Simply put, it induces bone remodeling. The osteoclasts eat away part of the bone tissue and mobilize calcium towards circulation. This happens in our bodies all the time as normal physiological method of bone remodeling. However, if the parathyroid hormone is consistently kept elevated, for example, in case of a parathyroid hormone secreting tumor, then this remodeling goes abnormal by consistently recruiting osteoclasts taking over the bone formation. Hence, the dominant feature then becomes resorption rather than deposition. So, this is why a consistent rise in parathyroid hormone or continuous administration of exogenous parathyroid hormone would lead to resorption rather than induction of bone remodeling. On the other hand, given intermittently, parathyroid hormone would favor bone deposition. Teriparatide is a synthetic form of parathyroid hormone, which is used as a treatment to treat osteoporosis, working primarily to induce bone remodeling unit, as explained previously. The resultant calcium mobilization from bone to blood would lead to increased load to kidneys, thereby worsening renal stones or nephrolithiasis in susceptible individuals. Similarly, it may also lead to hyperuricemia because of increased tissue turnover, bone tissue in this case. We know that any tissue which undergoes rapid turnover may give rise to hyperuricemia because tissue turnover involves release of DNA and RNA and thus degradation of its nitrogenous purine bases into uric acid. It has been observed, at least in animals, that at much high doses, it may lead to osteosarcoma. The other hormone, which is calcitonin, produced by parafollicular or C cells of thyroid gland, plays an important role in maintaining calcium homeostasis. Calcitonin receptors are G protein coupled and calcium sensitive. They decrease bone resorption by inhibiting osteoclasts. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!